Good afternoon, everyone. My name is Vaishali Sood, and I'm the health editor with the Quint. And today we're going to obviously talk about the story that's on the top of mind for everyone. India, as of July 16th, has hit 10 lakh number of cases of coronavirus. And India has reported its first case on 30th of January. It's taken us 5.5 months to get where we are right now. It's to further dice up the numbers. It took India 110 days to reach the 1 lakh mark and just 59 days more to go past the 9 lakh and then eventually the 10 lakh mark. India has also reported 25,000 recorded COVID deaths. In international standing, India right now ranks at number 3 when it comes to COVID cases. Now, to dice all these numbers and to understand them and what they mean, I'm joined today by Dr. Shaheed Jameel. Dr. Shaheed Jameel is a virologist. He's also the CEO of Wellcome Trust India Alliance. Thank you so much for joining us, Dr. Jameel.
Thank you, Vaishali. Pleased to be here.
So we are going to be shortly joined by Dr. Mathew Varghese as well. Dr. Mathew Varghese has played a major role in polio eradication in the country. He's an orthopaedic surgeon who works at Delhi St. Stephen's Hospital. He got caught up with a surgery, and we're hoping that he's able to join us soon. So to start off with, Dr. Jameel, I'm going to just start off with you right now. I know that media comes under a lot of attack for obsessing over the numbers, but when the numbers reach the 1 million mark, I think that little bit of obsession is valid. So I just wanted wanted your views and your interpretation of the numbers, the 1 million number in India's context. As a country as large as populous and as populous as India, what does this number really mean?
Yeah, so Vaishali, as you said, 1 million or 10 lakh is just another number. The way the outbreak is spreading, today we have reached 10 lakh, tomorrow we'll reach another number, and next week we'll have another number. So let's not fuss too much about numbers. I think there are a couple of other important points here. One is the rate at which infections are increasing on a daily basis. So we are roughly adding about 30,000 infections across India, which is about 3% daily rise is happening. Now, if we continue with this trend, then the numbers will keep going up, up and up. But the other thing to understand is that this is a countrywide number. Every place in the country is not increasing at the same rate. There are places, for example, Delhi is showing a downward trend now. But then it also means that there are other places that are growing faster. And the other thing you mentioned is, how do these numbers mean? What do these numbers mean in the context of India as a country? Yes, we are a country of 138 crore people. So, what is 10 lakh in 138 crores? If we look at it from that point of view, fine. But remember that these 10 lakh cases have been added in just the last 6 months or so, actually
right.
Less than that. So it's really the period which is worrisome. If 10 lakh cases were added over a whole year, for example, or over 2 years, one would not worry that much about it because, it would not overwhelm the capacity of our healthcare system and all that. Coming to the death figure, which is about 25,000 deaths right now, cumulative deaths, we are looking at a case fatality ratio of about 2.5%.
Right.
Which is about half of the global average.
I think it's at 4.5 with the global average, right? So,
right.
yeah.
There is another way of putting it. And just like you said, cases for a country like our size, cases per million people, for example, which would be low for India. Even the death rate per million population is low for India. The death rate is somewhere around 18 or something for per million population.
Right.
But there is a very interesting observation here that death rate is not just for India. If you look at countries across South Asia, Southeast Asia, you look at Pakistan, you look at Bangladesh, look at Nepal,
Right.
Sri Lanka, Malaysia, Indonesia, Philippines, Thailand, all of them have death per million population in single or double digits, usually below
Right.
20. But compare that to the death rate in US and Western Europe, and you'll find numbers of 400, 600. Belgium goes up to 800. Uh,
Mm.
so there is definitely something happening. I very strongly believe that there is a biological reason for this. And
Mm.
maybe we later we can discuss this if we have time.
Right.
But there are some interesting trends in numbers that we've been seeing.
Yeah, I just quickly want to introduce Dr. Mathew Varghese. He's
Yes.
joined us. Dr. Mathew, thank you so much for joining us. We just about started, and your audio's mute, sir.
Sorry, I was
Yes.
operating. I just managed to pull out him.
That's absolutely fine. I think doctors are excused, and so that's absolutely fine. We were just discussing the numbers broadly with Dr. Jameel, and we were talking about the fact that yes, India's hit 1 million, but in India's context, where does that 1 million sit? And as Dr. Jameel spoke about the case fatality ratio and India's numbers being far lower than the worst hit countries. I wanted to understand from you, Dr. Mathew, what could be the reason for it? One, as Dr. Jameel suggested, it could be biological. Could it also be India's abysmal, when it comes to recording deaths, I think about 22% that are actually recorded. So could that be the reason why the numbers are less, or the numbers are actually genuinely less, and that's something to be happy about?
First of all, let me clarify. It is very difficult to hide a death. If it is happening, it is seen by everyone and you can't hide a death. So the cause of death may be an issue. What is it that causing the death? You may not know because you have not done the testing, you have not done the sequential procedures required to diagnose the cause of death as being ascribed to COVID or whatever other primary or secondary conditions. So while we say this, in the certification of cause of death, there is a deficit in numbers. The official, I have said this before in an earlier interview also, if you look at the certification of cause of death, there is almost a 3-year gap between the current data and what appears on the website of Ministry of Health. So there it is 3 years back, the data that is there, 2017, and the number of deaths is ascribed as about 6.5 million or so. But there are studies, global burden of disease, and other independent studies which have pegged the death rate at 10 million or so, not 6.5. So we are missing about 3.5 million deaths.
Right.
But it's only in the cause of death certification and registration of deaths and births. So in real sense, it is not a missing death. So I am not willing to accept the fact that we are actually fudging numbers or we are actually getting the numbers totally wrong. We may be up and down a little bit in terms of the actual cause and numbers, but beyond that, I don't think it's too far wrong. And as Dr. Jameel mentioned, that's a very interesting point. We can say that the numbers and blame our bureaucracy and politicians for the numbers that are bad, but I don't think it is right to blame anyone for this. It's just that the recording is there and it will be there. Then my marginal up and down is acceptable. But what else is happening? As Dr. Jameel said, the entire Southeast Asia region, the numbers are all of them less than 30. All of them. I think Pakistan is around 25 or so, but all the others, and we don't know the reason. But look at Vietnam. How many deaths? What a close, compact population. living close to each other, no social distancing is there, and yet their deaths are so low.
Right.
So there is something beyond the numbers of not recording, not diagnosing, not testing. There's something beyond that which we do not understand, and we hope we understand it sometime or the other. There is some biological reason. There is no reason why Belgium should be in 800s and UK should be in 600s and US should be now close to 500, 400 something. That is enough. Why should those numbers be so high? And why should the numbers Africa? No one talks about Africa. Look at the numbers in Africa. The African numbers are also low. Even South Africa, which is one of the highest numbers, there also the number is less than 100, 79 per million population. So there is something in this part of the world which is different from that part of the world. And we are not looking at just the designation of testing and reporting them as COVID deaths. No. I have looked at, incidentally, I've been doing some research work on this. I've been gathering statistics. I've found that the deaths ascribed to other conditions have actually gone down. I would expect them to go up, but the other conditions have gone down and COVID deaths are slightly higher. So if you look at the total number, they are almost there. I have to complete the counting and all numbers. I'm looking at 1 or 2 hospitals. I'm trying to find out what's happening to the numbers. And at the end of the year, we would probably have a better picture. But there is something biological which you and I do not understand. The epidemiologists, the virologists, the immunologists all need to put their heads together and work together to understand what's happening.
Vaishali, if I may come in and add just one other comment, that if we were fudging data, then everyone must be fudging data in the region, and we must be doing it coordinatively. I don't think that's possible. So
that's good news. In fact, I mean, the point being that the number of deaths being where they are, I mean, any death is tragic, but if it's 25,000 and the numbers that are going up, I think yesterday was around 600 plus, the death numbers are still going up, but it's nothing compared to where the Western Europe and the US is at. So I mean, that is something to be looked at and certainly better understood. And how do we use that knowledge to treat people? That's something that certainly needs to be looked at. But in terms of pure numbers, I mean, the thing that as you said in the beginning, the speed with which the numbers have risen from 1 on 30th January to 1 million today, there were 3 consecutive lockdowns that India went through. There are large parts of the country that are again under lockdown currently. Is that what we did back then and what we are doing now, more localized lockdowns, which is a better strategy, or is that a strategy at all? Is a lockdown a strategy at all in dealing with COVID and preventing India from going to the next level? Dr. Jameel.
So we have to understand that a lockdown is, gives you time to prepare. Lockdown is not a curative in this case. So yes, lockdown really helped in the sense that the doubling rate of infection slowed down. When we started the lockdown, the outbreak was doubling at about 5.5 days. When we ended the lockdown, it was about 14 or something. Today it is 20 plus. So the lockdown helped in that sense. I think where we could have done better in the lockdown is to have prepared ourselves better. We did prepare, but we could have done much better. And what we did not foresee is the social dimension of the outbreak. We were so keyed in on the health part of it that we forgot to look at or understand the social and the economic dimensions of it. So by the time, those 2 months were over, the lockdown was becoming something that was giving only diminishing returns.
Right.
But even beyond that, some of these lockdown strategies I don't really understand. In parts of UP, for example, there's lockdown only on weekends. Now, what
Right.
does that mean? Is the virus active only on weekends? What is the logic behind that? I don't understand this. So there are some weird things happening. There must be some coordinated strategy to do these things. Otherwise, we it will be hard for us to come out of this very quickly.
Right.
To take it from where Dr. Jameel left, I would like to add here. I would like to make a classic quote of Robert Virchow. He said, medicine is a social science and politics is nothing but medicine on a larger scale. Now here, this emphasizes what we decide politically has a social implication, and
Right.
what we decide as having a social implication will have a health implication. So you can take it both ways. If your social structure is not congenial to a healthy society, you will have a disaster ready-made. If your health structure is not planned properly and in a robust public to tertiary care, all are important. The old recommendation that, people in this part of the world, they need to look at only public health. You improve the public health, your mortality statistics will improve. Fair enough. That has been taught to us by the Western world. And that has been taught to me in all my textbooks. Professor Jameel will also agree with me on that. If you improve the sanitation and improve the primary healthcare, you will improve the mortality statistics. What is that you improve? You improve the under 5s mortality.
Right.
You improve the infant mortality. But once the child has survived to about 5 years, then you go to our villages. Babajis are there 80 years, 85 years, 90, walking happily, walking 5 kilometers, doing everything. So they are healthy. Once this improves, then your need for that particular villager who has a cancer, that particular villager who has a heart disease, that particular villager who has a stroke also goes up. So your primary health care, if it improves, will need your secondary health care to be improved. And once your secondary health care is built up, you will need more and more people needing tertiary health care. And that will need more and more people needing quaternary health care. Unless your entire health setup is robust, fit enough to take care of every domain of health problems or all sectors, there is a demographic advantage that we have in this disease. But that cannot be the only reason why we have a younger population and therefore a lesser mortality than the others, because the vulnerable population is elderly. But even there, it doesn't explain fully. There has to be a biological reason also. So I am suggesting that where we have definitely a robust public health structure with a robust tertiary healthcare also built together, you're going to have a future of healthcare and society that is much better. That is what the exposure of this virus has been. The virus has exposed the weakness. But they'll argue that, no, it is good. That is why our mortality is so low. I don't think it is that. We need to look at other reasons why the mortality is low.
But taking off from what you're saying and what Dr. Jameel was saying, now currently the outbreak is largely in your bigger cities, right? I mean, top 10 cities are all like major cities. And, there's a Lancet report that's recently out that says out of the 627 districts in the country where coronavirus has already hit. Now, the numbers might be extremely low there, but when you move away from these 10 cities, when these 10 cities peak and the numbers start to go down, there's the next 10 cities, the next 10 states that you need to worry about, where your systems are not as are much worse off than what these big 10 cities have. So what are the learnings that we can take from these urban centers, and how do we apply them to states which are currently in a slightly better position, but how do we prevent them from reaching reaching the levels that a Delhi or a Mumbai or a Chennai is at. So I just wanted some suggestions from both of you on that front.
So, Vaishali, we say the situation is bad in big cities because that's where we're doing most of the testing. We're not doing that much testing in small towns, and certainly not in rural India. There are states that have abysmal testing rates.
Right.
And this is something that Soumya Swaminathan, who's the chief scientist at WHO, also said, that if you have to do 20 or more tests to find one positive, then you are in good shape.
Right.
Today, overall average India, we are finding one case in every 13 tests.
Right.
In Delhi, we are finding one in every 10. In Mumbai, we are finding one case after every 5 tests. That simply tells us that we need to increase our testing capacity. So there is really no magic here. The prescription is really the same as we have been saying from the beginning. You have to test to scale. You have to trace contacts of infected people very efficiently and effectively. And you have to isolate them, and isolate them in a manner where people have confidence in that isolation. They don't run away from the isolation. Unfortunately, this whole pandemic has been turned into a law and order problem instead of being a public health problem. So we haven't really looked at building trust.
Right.
So there is no other magic bullet to control it. I think coordinated strategy between center and states, breaking the country up into districts to look at what's happening locally and to have decision-making, effective, data-driven, science-driven decision-making to happen. Those are the things to do.
Right. Dr. Mathew, your thoughts on
the whole purpose of lockdown was, as Dr. Jameel said, to prepare us. The first 2 or 3 weeks were ideal for preparing ourselves for that. Prepare our staff, prepare our infrastructure, prepare our healthcare. What we are seeing today, 10,000 bed facility, 5,000 bed facility, that was to happen on the initial stages. We are having it now. So is there a problem of bed? No, a lot of them are empty. If you go around hospitals, a large number of beds are lying empty. We have enough capacity and more to admit patients. Okay, so this was to be done early on without closing down the other services.
Right.
That is critical. You have no idea how much of suffering the persons with other diseases have had to undergo. Every one of them with a chronic or an acute or even a person with disability. I've just completed a survey on it, and I found, the complaint that they said, 90% of them said problem of food. Problem of food. And I have said this earlier also. You have the Manrega, Mahatma Gandhi National Rural Employment Guarantee.
Right.
They do in Manrega to give employment in villages. They give them physical labor for building roads, building, infrastructure. Right. Where does the person with disability come in this here? He cannot do physical labor. So the entire group is out of the domain of doing this. Manrega income generation. And their problem is food, their problem is finances, their job problem is jobs. It is a social problem that is paramount. Therefore, the first, I might appear to be digressing, but I'm coming back to the point. The lockdown was essential for preparation. 2, 3, 4 weeks of clear endpoint to be given, and that was it. Now lockdowns are meaningless as far as I see it. If you look at the simple logic of it, when we locked the entire country down, there were 540 cases in the country. Today, we have 1 million cases, and we have opened up city traffic in Delhi, city traffic all over. You see the numbers that are there. So you may flatten the curve for some time, but that's it. Best is protect our vulnerable, make facilities for our vulnerable. Who are our vulnerable? Our diabetics, our elderly. Make sure your campaign paradigm shift must happen. Your campaign paradigm should be open up the cities. Do not have any more lockdowns. You're going to have starvation. You're going to have hunger. You want to protect them from that. You need to give them income. You need to build our economy. You need to do that. But while we do that, we can't let our elderly, we can't get our vulnerable. So your paradigm of campaign for protection should go from the normal, healthy, whom you're policing and it's become a law and order problem.
Exactly.
Those vulnerable who are sitting back homes. How do we protect them? People don't know. I see today morning, since morning, I was in the OPD in the morning, I saw 4 corona positive cases, 4. And when they come to me, do you know what they do? First thing they do is pull the mask down. Because it is courteous to talk with your face revealed rather than hidden. That's our culture. So we need to get out of this. Please don't do that. I would have kept telling them, please keep your masks up. Please keep it. We need to get our protection for our elderly, for our vulnerable, and your paradigm for campaigns should do that. Many of the campaigns have not reached the intellectually challenged. It has not reached the physically challenged. It has not reached the hearing impaired. It has not reached a large proportion of our population. We need to protect them also. So we need to look at from that perspective. I do not think locking down anymore has any meaning. We need to have strategic planning. If there are areas with a very high density, look at that, investigate that, and there may be some indication for testing, for research purposes, for testing, for localized large numbers beyond the numbers that we are seeing. I do not think there is a role for any further locking down. Keep it open, let people get back to work, let them earn a living, let them not die of starvation. A lot of them. In fact, today morning, the patient that I saw, when I told him, Doctor साहब को गलती हुई है, टेस्ट में गलत होगा, मेरे को तो कोई शिकायत ही नहीं है. That is what we are seeing again and again. मेरे को तो कोई शिकायत नहीं, कोई गलत हुई है. Report.
So that communication and then, making sure that it's reaching the last person.
But back home at home, there is an elderly. Back home at home, there is a diabetic, there is a kidney disease. All those, your paradigm for campaign should be to protect them. Protect them. But locking down, I don't think there is any sense in locking down anymore.
Right. I just wanted to talk specifically about testing. Now, I know that Dr. Jameel is antigen tests that have been introduced in Delhi and Mumbai to ramp up testing. Now, you're seeing in the daily numbers that the antigen testing numbers are more than the RT-PCR numbers. But does that really serve the purpose? I mean, if you're going to retest everyone who's tested negative, your testing ratio is going to get extremely skewed. So is that a reasonable testing policy for containment zones?
Yeah, see, the problem with the antigen test, as you rightly said, is that the sensitivity of the test is poor. When ICMR did validation of the test, which is being brought from a South Korean company, they found somewhere between 50 to 80% sensitivity. In the field, that sensitivity is going to go down further because even PCR, which is a highly sensitive test, is only about 70% sensitive in the field. And the problem largely is the sampling from the nasopharyngeal cavity. It is sampling that fails rather than the test that fails. So with a test with such low sensitivity, it may not be a very good idea to use that. If I were in their place, I would use something called, group PCR or mixing samples to do PCR. And people in the country have developed those protocols, have developed algorithms where in about 3 tests, 3 matrices, you can effectively test hundreds of samples. So I think we should have looked at those strategies instead of bringing in an antigen test. And even today, we don't know of the 100 tests done on a daily basis, how many are antigen, how many are PCR, to be able to make some sense out of it. So yeah.
To add on there, there is another thing that has come up. When they did an antibody testing in Spain, which has had one of the worst epidemics, they found that only 5% of the population had antibody positive. Only 5%. So they were starting to worry. But there is a paper which is from Sweden, from Karolinska, which looked at the T cells which were there. T cells provide you cellular-based immunity, and also it may be a longer lasting immunity. They found that there is a certain number that is definitely there with T cell immunity coming up. Now that is going to be useful. So many may be antibody negative, but may have T cell immunity. So that is why we are having all these confusions. And in fact, as I said earlier also, I am not in favor of testing as a general rule for the guidance to decide on protocols. No, I'm only recommending testing for research purposes. Other than that, I'm not comfortable for doing any testing on a population-based basis. I do not think there is any need. You may do it for medical indications. Yes, when you want to do a procedure, when you want to do something, not because you want to exclude the patient's emergency condition, you do that. But for protecting our healthcare workers, you may do that, but you may still have some negatives. As Professor Jameel mentioned, 30% may be negative. So you will still miss a number. So on a larger public health policy, I do not think you need to have a policy on testing at all. I think it is only for research and specific medical indications, not on a larger population-based scales.
Yes, so I just wanted to move, since we're talking about testing about antibodies, now there's a new research that's come out recently that indicates that, reinfections are very much possible because the antibodies built in your body may not last beyond 3-4 months. And this was done at Oxford, and it was a longitudinal study, and they found that the antibodies in the patients who had like a mild virus, the antibodies went away faster. So, our obsession with herd immunity, everyone talks about herd immunity as a solution or vaccines as a solution. Is that worrying? Is this study worrying, or is this just one study and we need to understand it more?
No, exactly based on, sorry, I'm answering Dr. Jameel. Exactly based on what I said just now.
Right.
They may be antibody negative, but they may have T cell immunity.
Okay.
And they will have the capacity to fight the disease. So you don't have to worry about that. I'm not so worried about that. So you can still have the immunity. And so when they are looking at only one component in these cases, they are theorizing that they have got reinfection. Because their antibodies are low, we really do not know. I'm not so comfortable. I've had patients who have tested positive even after 28 days. So so the norm is 14 to 21 days. But beyond that also, some may be positive. So if you've given up testing after some time and then come back and test and find something, or you don't find antibodies, I don't think you have to worry about reinfections and all that. See, historically, just look at history. No epidemic has behaved like this, where it has gone on and on and on and on and decimated entire population. It hasn't happened. There is a large number with immunity. Our job as scientists is to see majority. Look at the case fatality rate. How much is it? 3 point something. Okay, that's no big deal. But if that is so, but in real sense, it's 3.5 because your testing rate is not the total population. If you're testing the total population, your case diagnosed per death that is happening would come down further.
Right.
Okay, you're not testing the entire population, and you may still be missing 30% that are false negative. That's also there because the test has a sensitivity of only 70%. So you're missing because of your test limitations. You're missing because you're having a limitation of numbers because of population size, and therefore your case fatality rate is 3 point something. So it's a very small number in real sense, and it's not going to decimate our populations in large numbers. Italy is now coming back. Spain is coming back. It has killed a number which is large for that population when they did not understand the dynamics.
Right.
Italy was using ventilators every other patient. One of my consultants spoke to a consultant there and he was crying because he had done a fellowship in Italy. He said it's miserable every day whom to ventilate and whom not to ventilate. Because they were ventilating a large numbers. Now we understand the disease better. We don't have to ventilate a large number. It is a vasculitis. It needs a different management. The medication is different. We understand the disease better. We have the advantage of hindsight of what happened in Italy, what happened in Spain, and what happened in UK.
Right. In fact, that's something that a lot of critical care doctors that I was speaking with in Delhi were also saying, that, one of the reasons why they're able to save more lives in the ICUs in Delhi and in parts of India is because their understanding of the virus and the learnings that they've had from the UK, from Italy, from all these other countries that were impacted very badly in the month of March. And, those learnings are able to apply in their medical practice and are able to save more lives right now. Dr. Jameel, I wanted your view on vaccine and the study that I just mentioned. Is reinfection a possibility, or is that too early a concern?
Yeah. So the study you mentioned was done at King's College London, and they showed that the neutralizing potential of plasma goes down to almost baseline levels in about 4 months.
Right.
That doesn't mean that antibodies go down. It's the neutralizing potential, which means that it's the neutralizing antibodies that go down. But remember, that happens for every acutely infecting virus. The neutralization titers go down, but people have a memory to prior infection. So when the next infection happens, the memory is recalled very quickly, and that leads to neutralization of the virus. The other important concept to understand is that whether it's with vaccines or with people getting reinfected, we're not worried about infection. We are worried about disease. And there is hardly any vaccine that gives what is known as sterilizing immunity. Sterilizing immunity would mean protection from infection. Most vaccines will protect you from disease. The annual flu vaccine that you take, it doesn't prevent infection by the influenza virus. It just prevents disease. So these are important concepts to understand. Another study on T cells that has just been published in Nature, there was a prior study that came out in the journal Cell. Both of those show that there are abundant T cells that are made following infection. And in fact, the Nature study now shows that people who got the SARS infection in 2003 still have in them T cells that react to SARS-2. So that's good news for T cell immunity. Even people who don't seem to have gotten either SARS-1 or SARS-2, some of them show T cell signatures. And these are possibly people who got infected by the common cold coronaviruses. So I think a lot needs to be done, to be looked at. But so far, I don't think there is any cause for worry that vaccines may protect for only short periods of time and all that. Let all the data come out. We are only 6 months into the outbreak. We haven't really had time to follow patients. So I think it's not going to be so much of a worry. Today, I was just joking with somebody that vaccine has become a minute-by-minute story, just like Amitabh Bachchan. A minute-by-minute bulletin of what a vaccine is doing, what it is not doing. These things take time, but my hunch is that it will be fine.
Right. I mean, I completely understand where you're coming from, because I know that we are obsessed with the updates, and either we're obsessed with the numbers or the vaccine updates. So I see myself doing it like 3 times in a day, and there's so many vaccine candidates in the picture. But also, is there a serious concern that, the way vaccine timelines are being pushed, and that pressure that's coming in, that you need to get the vaccine out sooner in September and October, end of this year? There was also that 15th August date floated, of course. That the kind of pressure that builds, could that possibly impact the quality of vaccine that we finally get for this virus?
No, Vaishali, forget quality. Of course, it should not be done. It is unethical. Every person who is given a vaccine deserves to get a safe and effective vaccine. Okay?
Right.
But most people also don't understand that if, let's say, the Oxford vaccine or the ICMR vaccine or any vaccine, Moderna vaccine, shows efficacy tomorrow, it's not just a matter of showing efficacy. The vaccine has to be manufactured. The vaccine has to be distributed. The global vaccine manufacturing capacity is about 8 billion doses annually, which is about the population of the world. Now, all this capacity is not going to be making only coronavirus vaccines. Right. There will be other childhood vaccines that have to be made. So, the coronavirus manufacturing capacity would possibly be only in millions.
Right.
So everyone who is thinking that they will get a vaccine, I'm sorry to disappoint them, but they won't get a vaccine. Even if the vaccine was proven to be effective tomorrow, they won't be able to get a vaccine till maybe the middle of next year, because enough has to be made. Let's understand that.
As far as vaccines are concerned, I think the most important issue in a vaccine is the safety factor. That's the most important thing. Because what they do in the animal experiments early on, does it generate a sufficient amount of antibodies to fight and prevent a disease? That they get on from animal experiments early on. And then, is there a similar reaction happening in human being? That's when the human phase trial starts on. But the most critical aspect of a vaccine is the safety factor. And what you're talking about quality is the safety factor. Because vaccine is not given to a diseased person. Vaccines are given to a normal human being in the hope of preventing a disease. So your cure should not cause harm to the human being. That is the biggest concern. Therefore, it is going to take time. We have fast forwarded it sufficiently because of advances in technology, even to the extent that the Oxford vaccine is already being manufactured in bulk. Already being manufactured. The moment the safety green flag is shown, they will start distributing it. Then your ethical issue will come. Which country gets it? Which population gets it? Which ethnic group gets it? Which age group gets it? What kinds of issues will come up, and how much should be the costing, whether it should be free, which will be expensive. There'll be politics and polemics on that. And I think that's a long way off. And my suspicion is that nothing is going to be available which is safe before the next almost 9 months or so.
Okay. I know that Dr. Jameel has to leave for a call. I thank you so much for joining us, Dr. Jameel. Dr. Mathew, if you can just stay on, I have one more question for you. Dr. Jameel, thank you so much.
Thank you very much. Thank you.
Thank you. Dr. Mathew, I wanted to ask you, now monsoons have hit parts of India, and there are all sorts of fever illnesses. You've got dengue, you've got chikungunya, and all the other fever diseases that are going to crop up. There's the flu season coming up. What kind of a problem does it pose for hospitals? And, how do we manage, how do hospitals and as policy, how do we manage these diseases? Is this going to cause confusion, lack of beds? How do we manage this?
First of all, let me clarify, there is no lack of beds as of today. It is available. Large capacities. However, the hospitals are not functioning to the full system functioning that is there. It has been functioning on a lame manner because of restrictions that are there. Therefore, all specialties are not working to their full capacity. That's the biggest problem. I think we have had sufficient period for lockdowns. We need to open up. We need to open up all our healthcare facilities, and we have to take care of every patient with a disease, with illness, chronic, acute, emergency, critical. Every patient has to be taken care of. But this subgroup of corona should also be taken care of, and we have to plan for that, see how we can do that. How do we plan for that? We make sure, now therein comes your problem about fever. So all cases of fever are suspect corona, unless proved otherwise. That becomes an issue. So then it is a real difficult dilemma that you're going to face. This is going to be dengue season soon. And if we have dengue epidemic, you're going to have a double disaster. Double disaster, one because of corona, the other because of dengue. Both are going to be difficult to manage simultaneously. I hope and pray that it doesn't happen. But if it does happen, we have to have protocols prepared for that. How do we deal with that? Dengue can be diagnosed very easily by even a peripheral smear. My hematologist could diagnose dengue by just looking at the peripheral smear of blood. That doesn't cost you anything. You know, it's a 100-rupee test. It's not expensive, can be done, people can be trained to do that. So those triaging facilities where you diagnose dengue as dengue, and you diagnose a corona infection as a corona infection, those triaging templates have to be prepared, widely popularized and used. The other day I was in a meeting where this wonderful team from Aldi Institute, Apex Trauma Center, Sanjeev Bhoy and Tej Prakashana, they talked about POCUS, point of care ultrasound, because X-ray does not pick up a chest lesion from corona disease. You either need a CT scan or other advanced methods, or confirm it with a testing with PCR, that this is a PCR confirmed lung problem that is there. CT scan is an expensive proposal, not available all over. And once you do a CT scan for a corona patient, you have to sanitize it for next 2-3 hours. This point of care ultrasound, which can be done in every district, ultrasound is available all over. But because of the PNDT Act, which was put in to prevent the death of the girl child because of determination and feticide of females, you can actually use the same thing. A simple ultrasound of the lung can differentiate a simple pneumonia from a corona lung very easily. It will take you 5 minutes to make a diagnosis, and ultrasounds are all over in every district in India. You just need a certain number of people to be trained, and you can scale up. So when you have a thing like that happening, you need to train your healthcare people to prepare them. How do you triage? Triaging is a word which means that you're sorting out. Sort out one group into the other group. So triaging is what is need to be built into the protocols, into emergency care departments, where a fever comes, this is dengue, this is corona, this is malaria. So those distinctions will help us reduce the confusion, will help us reduce the burden of all these infections that is going to come in this monsoon season. That's all I'll say. You need to plan, prepare protocols, have operating procedures for this, and widely disseminate cheap, simple methods of diagnosing these conditions, whether it is dengue or malaria or it is corona.
Thank you so much for joining us, Dr. Varghese. We've run out of time, but I've had great insights from both you and Dr. Jameel, and it's been an absolute pleasure speaking with you. So thank you so much.
Thank you.